Hey everyone, welcome to our IG webinar on interventional glaucoma. This is Ike Ahmed. I'm in Toronto, Canada today, and it is cold here. I'm in the OR, and I'm pleased to be moderating this session, the special webinar with my good friend Gus Gazzard from London. We hope to cover some important topics in interventional glaucoma. We have some very special guests who have some really excellent expertise when it comes to MIGS and interventional glaucoma, and we'll introduce them shortly. And we hope that you'll enjoy this webinar. We already see a number of you already joining, which is great. I see we have a fairly international group of attendees, which is fantastic. We'd like to make sure it's interactive as well. So please use your chat or your Q&A icons on the bottom of your screen on Zoom, and we'll be monitoring the chat. We'd like to make it interactive. We'll try to get through all of your questions as much as we can, and certainly look forward to a very educational and entertaining webinar. So we're going to get started. I want to just, again, formally introduce Gus, my co-moderator. Of course, we all know Gus very well for his excellent work in providing high-quality evidence and guiding us in the right glaucoma therapies. He's at Moorfields, UCL, and has been contributing around the world. Gus, it's great to be doing this with you. I've enjoyed some of our podcasts, and this one's actually live, so we can't actually go back and change the wording here. So we have to make sure we're pretty careful and say things really well. But thanks for joining me.
Yeah, this one we're going to have to get right, so I better concentrate.
Exactly. So, Gus, maybe just kick it off a bit. I mean, this whole movement toward, if you want to call it interventional glaucoma, is kind of picking up a bit of steam. We've seen various technologies and approaches, come in. Some of them have gone actually as well. But what's your kind of big 35,000-foot level view on where we are with IG and where we're going?
I think where we are is realizing that it's an increasingly important part of how we're going to be managing glaucoma and where the shift's going to be over the next 5-10 years. I think we've already come a long way. Obviously we've pushed SLT right the way up the whole treatment hierarchy to primary SLT, and I think SLT is more interventional than medications were, and we've shown that actually that's better in a load of ways. I'm coming at it from a position of really hating taking eye drops and what they do to patients, and not believing that my patients take them so much. So I've been quite pleased to see that we've got some SLT-based and some MIGS-based data showing that non-medicated pressure lowering may even preserve vision better. But we can talk about that a bit more later. But I think that's where we're coming from. Where we're headed is I think we're going to see more and more of this. I think there's going to be a lot more appetite for taking patient compliance out of the equation for a whole load of reasons. What do you think?
Yeah, I think it's encouraging to see this. I mean, hey, listen, I mean, we grew up in the era of all these new topical drops, which I think were fantastic, seeing all these drug classes come out. But then we also realize their shortcomings, and I'm sure we'll talk a bit about it. But interventional glaucoma very much is really a mindset rather than even just a specific approach. It's really a mindset of being proactive, of finding the right time in the patient's journey to implement some form of intervention that doesn't rely on topical drops and the issues around them, as you kind of touched on as well. And I think that's what's super exciting. I think it's also opened up a lot of questions, understanding, where the pathology is, understanding how these treatments work, and finding the best patients for how they work. And I think it's exciting seeing, even, today, and we're talking about this today as well, how we're now finding new applications for lasers, for example. So I think that is really a shifting field. I think that probably the biggest questions we have is understanding what fits where. Thanks to your work, for example, with SLT, I think it's becoming much more standard to consider this first line. Although I think there still are some hurdles out there. And with MIGS combining with cataract surgery, we're seeing this becoming more commonplace, and we'll see where it goes with standalone as well. So yeah, I agree. I think it's we've come a long way. We have still ways to go, and I think the inertia is picking up, which is great.
Yeah, I mean, I think we've also got a lot of. I think it also really brings to the forefront the importance of data and the importance of good, robust, supportive evidence. I mean, there's an awful lot of things we've got to start choosing between now, and I think over the last 5 years we've seen a lot of people standing saying, "Well, in my hands, this kind of works, and I kind of like it." I think what we've now got, particularly with that brief episode of funding changes that we saw in the States at the tail end of last year, but also across Europe and across a lot of the world. I think we're seeing a lot more need for good quality, preferably randomized controlled trials. And so it's exciting that there's a lot of those that are getting underway, that there are a lot of those being reported and are underway to support the use of what we think is going to be quite an exciting new approach to pressure lowering and controlling glaucoma. So I think it brings us back to the data even more than anything else ever did. I mean, trabeculectomies, when they were the only choice, then, well, the data in the RCT were perhaps less important. But now I think we've really got to look carefully and critically and make sure that we're being presented with good trials data. So it's exciting that, you know, with new lasers, we've also got new trials.
I think you're right. I think, and that's really exciting to see. And I think today we're going to focus a little bit on some of the, you know, maybe more basic concepts, which I think are also important. It's kind of taking us back, going back many, many years, trying to understand how the outflow system works, how it reacts to treatment.
Yeah.
Which I must say, I think we skimmed over, right? We kind of just jumped to treatment. We didn't really necessarily understand, and we still don't understand as much as we should, you know, what happens in terms of the pathology in glaucoma from the proximal to distal outflow system. How, you know, do we take advantage of the anatomy and the physiology in the best way? And at what stage do we do it? So I think our speakers today will really help us to, you know, maybe share some light into this area. And then also, how do our treatments, for example, excimer laser, how can they best be applied to glaucoma, which up to this time, they really haven't been done widely. So I think it's important for evidence, but also it's also drawn us back into the basic science lab, so to speak, to give us more information.
Sure.
So good to see that.
Sure. I mean, when we didn't have enough, when we had so few options and so little we could do, then trying to drill down into where in the trabecular meshwork the greatest resistance lay, where in the outflow tract, and what proportion of patients had proximal or distal outflow tract obstruction, or whether Schlemm's canal was discontinuous. When we were just doing trabeculectomies, that was kind of immaterial and a bit academic and a bit geeky. And I think now it's incredibly important, because it really should be potentially guiding our choices and certainly guiding our thoughts and some of our research. So you know, I think you know, Carl, come out of the shadows and welcome to glaucoma. So should we it's down to me to introduce Carl Sheridan, professor in Liverpool, and renowned cell biologist who had an interest in wound healing and cell transplantation therapies for a number of different conditions. He is full-time academic, a senior lecturer in ocular cell transplantation at the University of Liverpool, and also has generated some of the most spectacular imaging of trabecular meshwork that I think any of us have ever seen. And I'm looking forward to seeing some examples of that again. So over to you, Carl, for some thoughts and your experiences on both angle anatomy, physiology, and aspects of the angle and trabecular meshwork outflow channel that apply to us jobbing clinicians who are trying to get that pressure down. Thank you, Carl.
Thank you very much for that lovely introduction. Perfect.
I've never seen Liverpool that sunny, mind you, but
you know, I did that deliberately because we haven't seen the sun for quite some time. It seems to be raining all the time, so it makes me feel a little bit better that I know it exists. So I'm going to talk today novel perspectives of angle anatomy and physiology, and hopefully give us one or two things to think about as we go through this. So here I am at work at the moment, and a brief outline: learning outcomes. As I'm a lecturer, I always have to start with those. So trabecular meshwork, we know, as we've always been told, up to 90% going through the conventional outflow pathway through the TM, and we don't really get to appreciate the TM until we start to see it in much higher power. So the one in the bottom right here, so we can see the trabecular beams and aqueous would pass on through here into Schlemm's and out through the collector channels. Imaging wise, clinically, we've got OCT, which kind of matches up with the histopathology we're seeing, and you know, other workers have been able to map out the collector channels. But one thing that is striking that we are beginning to appreciate more on the outflow pathway, this is Schlemm's canal all the way around the eye, and we can see it's not even. There's areas which are thinner and thicker than others. There's collector channels of different sizes as well. We've kind of known this for a long time. This is an old eye from the 1950s where they put basically rubber into an extended eye to look at all the vessels coming from SLEMS, and it's a multitude of vessels, and there's an EM on the right where they actually managed to capture TM in the bottom corner and the collector channels all the way through out to the eye. But what's really becoming topical, I'm going to talk now about the pump aspect of TM outflow, and hopefully this video will play. I think I have to just change back to, that's it, no, change back to arrow, so it will play. Was this observation a few years ago of a fibrin over a shunt, which was pumping nicely with at the same time as the beating heart of the patient. I'll just show it again continuously. And this really brought it back to the forefront of everyone's mind about how what the situation is for aqueous as it's passing out from the conventional pathway. So it's an important observation, and it's brings in the vascular pump aspects. And we've known this for a long time, that pulsatile aqueous outflow diminishes very much so in glaucoma patients. But it also brings in this concept of the model using physiological things that we've seen elsewhere, such as in the venous and the lymphatic system. And this has been created, so this is an organ culture model of human eye by changing the pressures. So the left-hand cartoon showing the different pressure models. So if you have IOP high and venous pressure low, we get the SLEMS canal shrink right down, and if we flip that, SLEMS canal can open right up. And then we also have there's more later models about the valves within SLEMS canal. So if we look here, if I get my laser pointer back up again, can you see the arrow actually? Yeah, you can see the arrow, so I'll stick with the arrow.
Yeah,
So
I can see the arrow.
Yep, SLEMS canal here, inner wall of endothelial cells. We're also starting to see these new inlet valves forming within SLEMS canal, which are involved in the passage of aqueous. We also have these flaps, which are periodic, just like you'd see within the lymphatic system as well. So covering over the outflow to the further vessels. And this is a nice histological proof of these valves within here, if we can see that, our mouse, showing the passage of microspheres through these valves within SLEMS canal. And this leads us to like the current working hypothesis from Murray Johnson's group about how dynamic the TM has to be within the constant movement that's occurring within the eye. So the TM has these lamellae. It's responsive to the pressure changes, so it's a constantly dynamic moving structure, which we've not really appreciated, I don't think, so much in the past. We have these inlet valves, again, which are really start to get more traction as well. They also act to connect to the SLEMS canal, and the whole thing is a dynamic process. So it's okay me showing you a nice cartoon, but is that really what happens to the TM? So this again is an explant model from Murray Johnson's group, where they've been able to modify the pressure inside and outside of the eye. And then they've actually managed to show one of the septums here. And this again is using OCT imaging within the eye. But what it really does appreciate is how much movement the TM can actually make. So this really hits home the sort of physiological whole movement of the TM as a structure and how important it is as a structure. So beyond passive flow, we do know that there's this pump action, and it's pulse driven, and this compression of the SLEMS canal and the pulsatile movement of the TM actually, forces the aqueous out of the eye, and it's this loss later on that we're seeing in glaucoma, which is causing some of the problems. So this gives us rise to not just the passive flow, but also the pump action of the TM. The TM cells themselves, I'm going to talk more about now, this second half of the talk, about we know the key players in the function of the outflow pathway. They're intimately associated with the Slemskal endothelial cells. Main function is obviously maintaining and the resistance and regulating that resistance, but they also have numerous other functions, such as causing inflammation, and it's a dynamic structure as well. So they're constantly phagocytosing, they're constantly turning over the matrix as well. What do they look like? So here's a nice porous TM. You can see the larger picture. See all the gaps within the TM trabeculae. There are some cells here, it's very cellular. And as we get older, the beams get thicker, much less cells, beams thicker. The whole thing, ECM, dynamically changes as we age. So what does that mean with outflow? Again, on the left, some more histology. But if we look at just the outflow facility, as we get older, we're actually losing our outflow. This is just in normalized. And this is the same in both human and the lower graph primates. So why are we losing outflow? Well, one of the things we think is because we're losing cells. And if we look at the number of cells from birth to the 90th decade, we're almost down to half the number of cells. So we start off with a lot of laborious cell counting in the past from my old supervisor, Ian Grizz, and 750,000 cells at birth. We're getting down to less than 400,000 by the time we get to 80. So we're losing a lot more cells. And this is even more so in glaucoma. So if we age match normals and those which have come from patients with glaucoma, whether they've had lots of other medical therapies or line of treatment, trabeculectomy was the first, in both cases, we're actually losing more cells. So this is interesting because I know as a biologist, I'm growing cells in the lab all the time. You give me a trab, I'm delighted I can get some cells from that and grow them. Cadaver eyes, we can grow them. But we also, as one of the things in ALT, is like maybe this is what some of the regeneration and that we're seeing in ALT is actually stimulating the resident stem cells. And that's one of the things we're really working on here in Liverpool, is understanding that stem cell biology as to how can we use them to be replaced, or understand how we can regenerate them. Because we do know there's a loss of these cells. We don't quite know where they've gone and why they've gone. But generally, there's the whole thing is there's decompensation of function. So over a period of time, the whole structure begins to lose its function. One of the things we do know is that the cells themselves change. We have these things called cross-linked actin networks, and I'll call them clans, which is always ironic in our lab because a couple of Scottish professors came up with the idea of clans, very fitting for them. But we do know that these clans form with increased IOP, with dexamethasone, all these things such as TGF-beta, which is increased in glaucomatous patients, cause these clan formations, which are very beautiful, but they have detrimental effects on the cells. The cells themselves can't phagocytose as well. And we know we need the cells to be mopping up the debris of melanin and things. They become stiffer as well. So if the cell's stiffer, that fluid motion that we saw in the TM earlier, that's a little bit more compromised. And the ECM, again, is compromised as well. So we're trying to understand that. By taking samples, we've been able to look into lab. This is something we haven't actually published yet, but we can see changing in smooth muscle actin expression from young eyes at the very top. You can see within different regions of the TM, as we get older, the tissue gets stiffer, and even more so in the glaucomatous. And this is with the brown staining of smooth muscle actin we're seeing. The cells themselves become senescent. These are almost like zombie cells, we like to call them. The cells, they don't die, but they're still metabolically active, they're dysfunctional, they cause other problems. In this case, the green stain is showing where the cells are. And if we look at that more histologically, younger eye at the top, less green staining within the TM, more cells. An older eye with POAG, more green cells and less cells as well. So what's happening to the TM cells themselves? I mentioned before, less phagocytosis. So as we get POAG, we're seeing more melanin pigment, and you see this clinically as well. So the cells themselves are filling up with pigment and not being able to function as well as before. It's becoming compromised. If we see on the left there, you see the TM seems to be a bit thinner as well. And all this is ECM changing. So one of the things we started to look at in the lab, So trying to understand this a little bit more detail to create better models. What we have here is a cellular healthy TM on the left in red and a glaucomatous one in green. And as you can see, the glaucomatous one, there's much less porosity there. So if aqueous is trying to pass through this, you can physically see the barriers that we can see there. One thing we then managed to do is actually strip away the whole cellular components and just to look at the matrix that's left behind. And we can see even then, if you take away the cells, this matrix component has really changed. So even if take it away, on the left, you can see porosity is still maintained in the healthy HTM, but in the GTM, still a lot of excess ECM and hard to get through. But what this has enabled us to do with latest technology is use micro CT to try and understand and visualize the TM even more so. And this now on the left is not a CGI or anything. So this is actually X-ray tomography of the TM structures. And as it's passing through this video, you can appreciate the beams of the TM in much more greater detail. You can see the porosity throughout the TM. That the ridge at the top is where it's the iris has been taken away, but this porosity is there to see. On the right now, what we're seeing is a glaucomatous TM, and the image goes darker because the whole thing is much more compact. So even the CT images can't pick it up. You'd appreciate the whole thing is thinner, the porosity is not the same, and you can see a real marked difference in the structure. And I think now as we begin to recreate the TM, so we're using these mathematical modeling. We're also using this to create TM models in the lab so we can understand the biology that bit better as well. So in kind of a summary of the imaging of the TM, we know we're losing these changes, losing the cells. There's an excessive loss more in glaucoma. We lose stem cells as well. I haven't touched on that much. Dysfunctional cells as we're aging and more so in glaucoma. The ECM and more importantly, the porosity and stiffness is changing. So to give some sort of thoughts and future discussion for later, just before I show some more images. So the outflow is dependent both at cellular level and the physiological competence. So this gives you much more to think about clinically as how you're going to target the disease and whether we should be shifting our innovations to, whether we're just removing out the old TM or are we losing out on some of the pump mechanisms and should be using that natural machinery and also when to target the TM. As I mentioned before, there's this decompensation of function eventually. So as we know, this is sponsored by Elios and they allowed me to play with their lasers. I'm not a surgeon, but I work with them and we managed to do some surgery on some post human eyes. And as you can see, we get a very, very nice clean. And I call this a very nice clean stain, but everyone says, oh, there's a bit of a funny edge here. But we're down at the micron level here, so you wouldn't be able to see this difference, but you can see quite clearly this beautiful electron microscopy. So obviously, we've looked at this at higher power now with a micro CT. And this was, to be honest, beyond my wildest dreams, how nice this looked. We're able to actually zoom in. So we're going in through the Slem's canal now. So this is looking in through Slem's canal, and you can see the hole has gone through the TM and is allowing the aqueous to pass in a nice controlled way into Slem. Hasn't come out the other side or anything like that. So very, very delighted when we managed to get these images, and I'm sure you agree.
Beautiful.
It's something to talk about. Obviously, it's not just me that does that. In particular, Devon Crouch is the PhD student working alongside me and Lucy as supervisors, and he's qualified for his private last month or just end of last year, sorry. He's now working in the lab as a postdoc. So I'll leave that there with you.
It's such a shame doing this on a kind of webcast because you can't hear anyone sort of gasps as they realise that's actual tissue and not some kind of CG reconstruction AI generated mock-up, that it's actually the histology you're flying through. I mean, it does my head in. It's such a beautiful image.
I'll leave it running.
Yeah, I think you should. It's amazing. I mean, to be honest, I also really liked the normal human and the glaucomatous histology that you showed, because that starts to really bring to life for me some of the pathology that we don't normally think about. And what I was saying earlier is this way that interventional glaucoma is beginning to pull our minds back into tissues that perhaps we didn't pay that much real attention to. I know we fired lasers at them occasionally in various different circumstances, but we weren't paying them that much attention before MIGS. And now we can see we're reminded of the complexity. And one of the big things for me, I don't know how much you think it's relevant, but one of the big things for me is the idea that we can bypass this or affect this or treat this area, but without too much destruction. Because I mean, I came into MIGS with trabectome, and I don't know how many of you guys used trabectome, but it was a hell of a beast, and it caused a lot of tissue disruption. And now looking at these pictures, you realize how crude that must have been. Ike, what do you think?
I think that some of the mysteries we have with, for example, patient response, I think are I think Carl shed some lights on some of these things. I've always felt that, we move from a reversible outflow disease to an irreversible outflow disease at some point in a glaucoma career. And if we can figure the right timing for this, and I wish there was a proper diagnostic, I don't know, Carl or Gus or Ahmed, if you have any thoughts on this, but I mean, if we had a proper diagnostic to tell us at what stage of outflow disease and dysfunction this patient has, and also where the obstruction is or where the dysfunction is it the TM, canal level, distal outflow system? I think if we have some of these diagnostics and predictive factors, I think it would make our procedures so much more predictable and so much more reliable. So
Yeah,
I think those are important aspects to the next era of interventional glaucoma is understanding. I mean, it's interesting, Gus, when you do SLT languished for years as sort of a fourth line option, pre-trab option, and the results were not great. And all of a sudden, we see an excellent study done earlier, I mean, really early, and we see really dramatic results. And I think part of it has to be the pathology is different, even though it's glaucoma. Glaucoma is different depending on what stages there are. So I'm excited to kind of tap into our basic science knowledge to help inform us about where do these technologies fit. I mean, to me, that's a very interesting topic these days when it comes to these options. We have options available where they fit. And I don't know, if any of you have any insights into that, into sort of thinking about that level. Are there surrogates we can use to tell us?
I think that's going to be the big question. I mean, I think you've nicely identified two of the big questions that we would love to be able to ask sitting in front of a patient. One is, I think there's three, and there's one that's hidden in what you said. One is, the first thing is there that disease course? Is there that point of no return where you're not going to get anything by hitting that TM with laser because it's too far gone, and even if you tickle up some stem cells, it's too late. So that's the thing I would really like to get a handle on, and I'm going to ask Carl that in a second. But then the other two questions I think you pinned down were, it would be great to know if you do have this point of no return, can we identify it, or even just identify surrogates or risk factors for it? Because it's not simply age. We didn't find an age relationship with the response to SLT. And then the other question is, at what point of the outflow channel pathway are we getting resistance? Is there any point bypassing trabecular meshwork in this patient if in fact they've got a dysfunction of their collector channels? Maybe we should be burrowing through the sclera and doing a totally new thing. Maybe this patient is the perfect patient for having a really beautiful sculpted opening in their trabecular meshwork, bypassing that proximal blockage, because everything beyond that is fit and healthy and working well. And I think that's a really sort of interesting idea about what we might be asking ourselves. Carl, do you think do you think there's a point of no return in the pathology?
Probably, yes. I mean, yeah, like I say, I call it a decompensation. It's a gradual effect. I mean, I think there are these very end stage, very no cells left, very almost fibrotic stiff tissue that is probably past the point of return. But there are those earlier on. We know that, like from laser, you can regenerate. There is some sort of regeneration capacity within the TM. So you can put stem cells in there. and you can have that regeneration of the resident stem cells, not just of the stem cells that you put in there in animal models. So there is that capacity to do that. I mean, we've been doing a lot of work on looking at where the stem cells are and how, and I'm presenting at ARVO and how we can modify their responses. And we know that we lose those stem cells with age, and even more so with glaucoma. So one of the things we were looking at was TGF-beta2 and TGF-beta1 to see how, because that's elevated in our glaucoma patients, does that stop the stem cells from differentiating? Was actually the hypothesis we addressed. But what we found, it was like the elevated TGF-beta was pushing the stem cells to differentiate. So it seemed to be forcing out and losing that population. So maybe that's part of the problem of the cell loss, is that the stem cells are being flushed out because of the disease pathology. So, you know, maybe if we've gone too far, and then can we come back in and regenerate? These are studies that we really need to get a hold of and try and do. But I think now, by having better models as well in the lab, we're going to be able to create that, because now we can generate iPS stem cells as well. So we've got a few cell lines of our own.
I think you've got a lot of work on your hands. I think we've also got even more work on your hands, because there are a couple of questions coming in for you, just suggesting what your next PhD student should be getting on with. I think the first
to on supervising more students.
The first of those was a question talking about back, and then I'll let Ike move on to the next one. Have you got any information on back effects on TM using your sort of histological studies, whether in animal models? I mean, it's a bit of a big ask to see if you can get that in human eyes, because you probably don't have the clinical data or the access to the tissue. But have you got animal models of back exposure causing histological change? I know it's a big part of our fear of medical treatment.
No, in short. So which treatments are you talking about? Any treatments at all within the
just preserve medication with benzoyl chloride, because we know that it can accumulate in the trabecular meshwork, and it is said to be toxic to trabecular meshwork cells in culture. So it'd be interesting to know if there was a histological correlate.
Yeah, I mean, a lot of the tissue that this is something we'd love to look at. I mean, we have an eye bank and we're collecting samples from theatre, but we don't have enough samples to look at that and have, I mean, that's something that we're planning for the future, in having this constant, you know, the data platform and having all that from the patients to all the way to deceased donor. It's not something
you and I have got to talk over a beer. Ike, what was the other one you were going to move on to?
I think it's a very interesting and provocative question. You know, are we harming the outflow tract with our medication? Now, that could be subconjunctival. We know that can happen, certainly. But also, does it happen at the TM? Does it happen because of preservative? Does it happen because of reduced nutrition and aqueous flow, certain drugs? These are very provocative, interesting questions that we probably need to get a better answer on, that we need some of this basic science, investigations. There's a few questions. We want to get to them. And I know that Ahmed has a question too, but this next question is about corneal hysteresis. Would you look at the trabecular meshwork in eyes with high and low corneal hysteresis to observe these differences and maybe implication of that? I don't know if you have any thoughts on that. I don't know how familiar you are with hysteresis, which is basically a measurement, for example, of looking at the corneal viscoelasticity. How stiff is the cornea? We've seen data, population data, that a stiffer cornea, for example, implies a stiffer biomechanical eye, which means that it probably cannot handle a velvet IOP as much, and that's a risk factor for progression. And I guess the question is that, can you look at TM at the level you do to look at the level of, for example, TM stiffness?
Yep.
And correlate it to corneal hysteresis that can be measured clinically, and can that imply maybe some conclusion about the trabecular meshwork function and irreversibility?
Yeah, I mean, that's a great question. I mean, stiffness is obviously key. We can look at, I haven't done this where we haven't tried to match what's going on in the cornea or the transition to the TM region stiffness. Measuring the stiffness in the TM in the lab is quite hard. You can do atomic force microscopy. It's quite variable, but we can see huge changes. It's easier at the cellular level rather than the tissue level for us in the lab. And we can show that changes in stiffness occurs to the cells as well as to the ECM. So you can put healthy cells on glaucomatous TM and the cells themselves become stiffer, and you can see that quite clearly. One of the studies we're looking at is looking now to see the changes of the stiffness with post-laser as well, and what happens when we injure the TM structure, how that stiffness, whether it radiates out or not. But it's a really good question about, you know, the stem cell interaction, even at the limbus and limbal epithelial regeneration, it changes the stiffness of that crossover region has a real impact on that as well. So it's a fascinating.
Yeah, they might be onto something with regards to, again, a diagnostic piece to help us out.
Yeah.
We're going to move through because there are a bunch of questions here, so I want to get through them quickly. Maybe we'll jump. We'll get Ahmed to jump in here for a comment or two. Ahmed, do you have a question or a comment? I know you're going to be speaking next.
Yeah, so it was very interesting to see all the ECM accumulation and glaucomata size, and got me thinking about one of the theories of how SLT works, because SLT is supposed to activate the cells, the chemical reactions and the remodeling of ECM in the trabecular meshwork and improve the outflow. And it might be interesting to see a post SLT eye and how it looks like a glaucomatous eye. I don't know if you have them in the lab or a model like that. And I mean, I've worked with whole eye models, and I know, you know, the challenges there, but it seems to how you have a fantastic model there, and it's really working really well. So if you have those the ECM and then treat it with you know, SLT, would there be a difference in like an ex vivo model? And the other thing is about those biomarkers. So if there is an increase in ECM, if we can manage somehow to find, you know, label the ECM somehow by like a, I don't know, a dye or something. We were looking at extracellular vehicles and things like that in Nottingham. But this could be a nice biomarker, because if we know that one of the hallmarks is the accumulation of ECM in glaucomatous eyes, and if we can find that there is more significant ECM in the trabecular meshwork, then the trabecular meshwork surely could be a level of resistance there. So, and this can lead to say, well, yeah, we'll work on trabecular meshwork comfortably now because at least some of the problem is a trabecular meshwork. But I don't know if you have any thoughts about actually labeling ECM in trabecular meshwork on live samples.
Yeah, on live samples, not so much. I mean, Darryl Overby down in London has done some great work on ECM changes and as well, and it's showing that it's a dynamic process, and that it can be, you know, you can see it changing, and different areas are changing the rate of flow within the TM over time within mouse models as well. But yeah, it's for your first question, SLT. I'd love to get some SLT treated eyes to look at the pathology, and similarly to try and recreate it in our model. I mean, we are going to do a study with the Elios system looking at posting, but it would be really nice to do SLT in tandem and look at the different responses to the TM, the different inputs. Same with the different mix as well, depending on where they're placed.
Yeah, it could work well with animal models, I think, as well, Carl,
yeah,
because they're live.
I think I think it's really exciting because it's dragging us clinicians who've been thinking like simple plumbers for so long back into some real science, and there are important clinical outcomes from what Carl's doing, which is that with such an exquisitely balanced structure, then probably doing less to generate the same sort of pressure reduction is better in the long term. If we can get a nice kind of neat cookie cutter punched out opening that gains access into that schlems, then it may be that that's better than something that's potentially more disruptive or destructive. I think that's really exciting.
Yeah, I completely agree. Where you target thinking long term, you know, looking at where the outflow part, where the resistance is in the targeting, you know, following on from Ahmed's comment, can you target label areas where you want to be targeting even more? So the dialogue now that's happening between clinicians and myself, because you can all see it and talk about it, visualize it, and then look at why I want to shoot it in this little bit, because now you can, is It's fascinating.
Very exciting.
Well, I think that we've covered a lot of great topics here, and I think that as we move into this interventional glaucoma field, I think that both Carl and Ahmad have really given us some excellent basic foundational concepts in understanding the right patients and the right advantages and disadvantages of the different approaches we use. And I think that we need to use this information in the best possible way to decide the right treatment paradigm. In my opinion, I think that interventional glaucoma is best treated early in disease. I think that both presenters have shown the advantages here and even the expectation in terms of outcomes here. And that's, I think, the whole point. Is I often say glaucoma is only young once. We have a chance to really change the outcome in the outflow and also on the functional level, the back of the eye, by intervening earlier, and the impact of that on the patient's lifespan will be also greater. So I think that's the drive we have. It's as often in these sessions, we often get more unanswered questions than answers. So I think it's given us more things to study, and I hope all of us here will take it home to do that. But as always, I always want to hand it off to my my gifted partner Gus to give us some real great pros to take home and synthesize as we finish off. So I want to thank everybody for attending, and I'll hand it off to you, Gus, to finish us off.
Well, thanks very much, Ike. It's been great. I always learn a great deal hearing from Carl and Ahmed. I think it's a great opportunity to revisit some of the trabecular meshwork biology, physiology, and to really remind ourselves that it's such an important structure that we are perhaps having been for many years taking for granted. I think the pulsatile flow story is going to be interesting over the years to come. I think that the complexity of the meshwork and really the message that maybe less is more, maybe careful targeted excision that you can achieve as Ahmed described with eczema, maybe a better option than some of the much more traumatic procedures that are hoping to tackle the same tissue, but probably doing so with a lot more generation of scarring and secondary changes that we can't really predict. So that's been my main take home from today. I really think one thing we should say is that this whole podcast and the presentations will be available, I think within the next week or so, from the educational site from Elios. And with that, I'm just happy to say good night to everyone, and thank you very much for your time spent listening and giving up your well, I suspect for most people it's the evenings, so giving up your time and evening. So thank you very much, Ahmed and Carl and Ike. Always great to see you. I hope to see you soon.